Welcome to the WebMD Health Discovered podcast. I'm Dr. Neha Bhatak, WebMD's Chief Physician Editor for Health and Lifestyle Medicine. About 53 million U.S. adults are diagnosed with arthritis. How is arthritis diagnosed? When does it usually occur? And what are some of the symptoms and treatment options? In this episode, we'll break down what arthritis really is and why it's so important to make sure we differentiate it from other musculoskeletal conditions from a rheumatologist's perspective. We'll look into the common symptoms of a variety of types of arthritis, from inflammatory arthritis to osteoarthritis, and then we'll also dig in a little bit to infectious types of arthritis. We'll cover the primary treatment options available, and we'll learn why they can vary significantly depending on the type and severity of arthritis that you're diagnosed with. Here to walk us through this topic is Dr. Robert McLean. Dr. McLean is a rheumatologist and member of the clinical faculty of the Yale School of Medicine as a clinical professor of medicine. He practices in New Haven, Connecticut with Northeast Medical Group of Yale New Haven Health and is a past president of my medical professional home, the American College of Physicians. Welcome to the WebMD Health Discovered podcast, Dr. McLean.
Well, thank you very much. I'm delighted to hear that it is also your professional home.
Before we dig into our conversation around arthritis, I'd love to dig into your personal health discovery and your aha moment. You said you love talking about arthritis. So when did you discover this love of this topic?
Well, people will sometimes wonder, was there a particular case that was really enlightening or interesting? Was there a particular mentor? And I think in reflecting that going through both medical school and residency, I encountered several attendings who were rheumatologists, senior physicians. And all of them seemed to have a few attributes in common. They were all smart. They were good with patients. They were really good generally at taking a good history and doing a good physical exam of joints and muscles and things. And they were all happy. And I said, gosh, there's something common here. And they were all just kind of really good role models. And so through training, it also occurred to me when different teams and specialists couldn't figure out something, they'd say, well, maybe it's rheumatologic. Let's call them. And so it seemed like the rheumatologists were kind of the people who figured out the problems where no one else could, which was kind of a nice place to be. And then through the 1990s, and we'll get into this a little bit, the treatment options exploded with some of the advances, what we call biologic therapy. So that's how I kind of ended up there. And you end up being the kind of the primary care doctor for people who have a lot of chronic conditions. And I really like primary care. In fact, I practiced basically 50-50 primary care and rheumatology for pretty much the first 20 years of my career. So I've been focusing mainly on rheumatology about the last 10.
Well, thank you so much for sharing that. I think that as a primary care doctor myself, I completely understand much of what you're saying. So let's dig into the topic for today, which is arthritis. That is a pretty large umbrella term. Can you help us define arthritis? And then we'll sort of dig into how do we sort of then delineate what type of arthritis one might have.
Sure. So I love to dig into the meaning of words. So if you look at arthritis, for those who maybe have a little Latin background, anything that has itis on the end usually refers to inflammation. And arth kind of stands for joints, I think, in Latin. So it's inflammation of joints, which is actually a misnomer because not all of the joints that are actually truly inflamed as we might think of it. It's more pain in the joints, or it's a problem in the joints. So people may see, if they look at other terms, there's a term called arthropathy. And pathologic is something is wrong. So a better term in actuality is probably arthropathy. There's a problem in the joint. It's not always inflammation. But to your point, we'll get into what are the different types and how do you kind of tell them apart.
So help us sort of think about how you differentiate the type of, so whether or not it is an actual arthritis or not, And then what are some of the other constellation of symptoms that you think about and look at to make your diagnosis?
So a scenario which I'm sure you've experienced and many do is somebody's developing pain in their knee or some joint. And they'll call up the office and say, I think I have arthritis. Can you send me for an x-ray? And my first answer is, well, I really need to examine your joint, move it around, poke and prod to see what's going on. Because the first thing I'll ask somebody is, okay, well, where does your joint hurt? Point with one finger where it hurts. And it may be behind their knee, it may be on the top, it may be on the side. It may not be over the joint, it may be over the bursa, this kind of pad next to the joint. And so I spend a lot of time really getting a sense of where someone hurts, how they hurt. Is it more day versus night, with motion, at rest, examining them, both looking for pain with passive range of motion, or where we move it, but they don't do anything, or actively where they're doing the moving, thereby using muscles and tendons. And so you kind of really need to examine somebody to sort out what you think's going on. And then maybe an x-ray might be helpful, maybe some lab tests might be helpful. But kind of the initial question is, well, what kind of arthritis might they have? So I get beyond the, well, listen, just because your joint hurts doesn't mean the pain's in the joint.
Right.
There's all these soft tissues around the joint, and you really need to examine someone and take a good history to figure out, is it their tendon, their bursa? Is it the cartilage inside the joint? Is it the muscle around the joint? So there's is the ligament that got pulled. There's a whole bunch of things that we in rheumatology and orthopedics also get really good at examining. But quite frankly, most primary care docs, unless they do a lot of it and really pay attention to it, they're too busy taking care of heart disease and hypertension and high cholesterol and diabetes to really get that good at it. Some do, but a lot just aren't comfortable, and they have a lower threshold to do some tests, which sometimes kind of leads you down a rabbit hole, which we can get into later. But as far as explaining to someone if they have what seems like a true joint hurting, I'll explain to them that there are really two large categories of what I would call arthritis. There's osteoarthritis, kind of generically referred to that as wear and tear. Everyone gets some osteoarthritis if you get old enough because things do wear down. The cartilage padding gets worn down and you get a little bit more friction in the joint. And that can be really severe or it can be fairly mild. So that's osteoarthritis, by far the most common. And then there's this other family of types of arthritis that we call inflammatory arthritis, where for some reason the joint is getting inflamed. And there are kind of three major categories there. There's autoimmune, the biggest of which is rheumatoid, but autoimmune things also include psoriatic arthritis, lupus, a bunch of others. Then there's what I would call crystalline arthritis, things like gout and something else called pseudogout. And these are not that uncommon, where some crystals that form in our body end up depositing in the joint and cause this profound inflammatory reaction. And then there's kind of infection related. So someone could have an infection in the joint. They could have some sort of immunologic reaction related to an infection, like Lyme disease, like different viruses, where people can get an inflammatory arthritis, but it's kind of related to the infection. There's something called parvovirus. People who are school teachers exposed to kids who get this relatively common infection. If they get exposed as an adult, they may get an inflammatory reaction. Hepatitis B and C can get types of arthritis. So there's a bigger category there. But the biggest, probably that gets the most press is rheumatoid arthritis.
Right.
Although with all of the direct consumer ads on TV for all these new biologic agents, everyone's worried that they have psoriatic arthritis now because they have these great new medicines, which is, we'll get into.
Yeah, so I think that just to unpack some of what you said, I think is really important for patients to understand or people to know is that there are different categories, and you might determine or you might sort of lean one way or another even before you go down the route of testing and x-rays, etc. And some of what you're thinking about is age, you mentioned. Some of what you're thinking about is the time of symptoms, the joints that are involved, and this sort of, again, a term called inflammation. So, can you help us think about what you're thinking when you're thinking of joint involvement?
So typically, because it gets the most press, is rheumatoid arthritis. And rheumatoid arthritis is typically, there's always exceptions, so I never say never, is typically symmetrical, affects both sides of the body, and usually has a predilection for small joints of the hands, kind of the knuckles at the base of the fingers, and then the first row of joints of the fingers called the PIP or proximal interphalangeal joints. And it can also affect parallel joints in the feet. It can also affect the knees and the wrists. But if somebody has both hands with that row of joints, that's kind of, I'm thinking, oh, this pattern really could be one of the different types of inflammatory arthritis. Psoriatic arthritis can look like that. Psoriatic arthritis, which is also not uncommon, probably 10% of people who have psoriasis may develop some sort of arthritis at some point in their life, and that's fairly common. Psoriatic arthritis can look like rheumatoid arthritis in terms of pattern, but it can also be kind of spotty. It can hit just one joint, the wrist or the knee or to one finger. It can kind of wear many different presentation hats, and it can also kind of affect the back of the spine. But so I'm asking people, where do they hurt? Which joints? Does it affect their back or not? Like, true inflammatory arthritis in the back, which is very different from wear and tear. Pattern. So I'll ask people, how do you feel getting out of bed in the morning? I will never ask someone, are you stiff in the morning? Because everyone's stiff. I don't want a yes. I want to kind of like set the stage to kind of get a sense of how much. So I'm like, okay, you're a little bit stiff. Well, how long are you stiff? Oh, 5-10 minutes and I'm okay. That doesn't sound like inflammatory arthritis. When they say, I can't move and move around for like an hour or two, at that point, my radar go up like, wow, this is prolonged morning stiffness. Degenerative wear and tear arthritis doesn't tend to have that. So if you think about the wearing down of joints, they hurt more in general as people are on them more. So wear and tear osteoarthritis tends to hurt more as the day progresses, and they're using their joints more. Oh, I'm using my hands a lot, cutting stuff in the kitchen or at work outside. That just sounds more osteoarthritic than inflammatory. If they say, I have to run my hands under warm water to loosen up in the morning, that's sounding inflammatory, and it lasts, an hour or so. So which joints are involved? The osteoarthritis tends to be more weight-bearing joints. Think about trauma or, kind of wear and tear. So knees, hips, sometimes into the feet a little bit. They wear a lot of dress. Hands in the osteoarthritis will affect the base of the thumbs a lot. If you think about it, the base of your thumb moves every different direction, and your grip, you're using it all the time. So a lot of people will get pain at the base of their thumb, but not the rest of their hand. And that is most typically osteoarthritis wear and tear. The other thing where osteoarthritis frequently hits is the end joints of the fingers, what's called the DIP, the distal interphalangeal joints, also called Heberden's nodes for those who like history. And though people get these like knobby, gnarly, and large joints, now people go, why am I getting this? I'm not like walking around on my hands. Where's this wear and tear coming from? But it seems like a lot of osteoarthritis probably does have some sort of a genetic component. I mean, some people will get things like that in their hands in their 40s or 50s, not in their 70s or 80s. And I'll ask them, the first thing I'll say, well, what did your mom or your dad's hands look like? And they'll look down and they say, oh my gosh, they look just like this.
Mm.
So there are some families that have been studied over the years through different rheumatology studies showing how you see patterns in families. There's something about their cartilage or the wearing of their joints that just some gene kind of turns on at age 40 or 50. And the next thing you know, they're getting it without any clear explanation. So those are kind of the general rules we tend to use.
And so before we jump into treatments, because I definitely want to jump there, I would be remiss. We're both very interested and involved in climate change and health work. So I'm very curious about how you're thinking about Lyme as part of your diagnosis. Are there certain characteristics that you think about that are more typical of Lyme arthritis?
No, interesting. I'm here in Connecticut. So that's where Lyme, Connecticut is. So it is high on the radar of most people. A lot of ticks around, which carry not just Lyme disease or borreliosis, but a couple others. So Lyme was first discovered, as you may know, when there were a bunch of kids on one single street in Lyme, Connecticut, who all were being diagnosed with what was called juvenile rheumatoid arthritis, which is a situation where frequently in kids, if not that frequent, they'll get isolated swelling of a knee and not that much in the way of other joints. And quite frankly, it was a very astute mother, I believe, in Lyme. It was like, this is crazy. Why do we have, 5 or whatever number of kids on one street getting this relatively rare condition? And I believe she contacted the CDC and said, there might be something weird going on here. And the CDC then contacted some people they knew at Yale Rheumatology who ended up investigating. This is 1974-5. So the knee is classically the joint that's involved in true Lyme arthritis. But that's not an acute Lyme arthritis. That's like 6 months later as part of the body's response to untreated Lyme disease. Lyme disease presents after a tick bite, usually days to a couple of weeks after the bite. And the bite leaves a kind of the bullseye rash, classically, although it's controversial how often that's there, but it's frequently in a place that you may not see on your back, the back of your thigh, whatever. And that rash then can go away within a week or two, and the person never even knows. But if they are sick systemically, it's like the summer flu, as they say. So if somebody has like fever, achy, just feeling really bad, and it's summertime, obviously we now think of COVID, but Lyme disease is kind of that setting, especially someone who is outside a lot. And you always ask them, hey, have you had a tick bite? So if somebody has joint symptoms, I would say typically one of my questions here in Connecticut is, any recent tick bites or rashes or any concerns about Lyme? And sometimes they'll say, well, I had a tick bite and I saw my doctor. They did a Lyme test a week or two later and it was negative. I'm like, well, that's reassuring. However, sometimes the antibody response, which is what we're typically measuring, takes at least 4 to 6 weeks. So if there's any question that someone is now having persistent joint symptoms, I'll recheck a Lyme test a couple months later, and you'll sometimes find it's positive.
That's really helpful. So you've really helped us think through symptoms. You've helped us think through how you're thinking about differentiating the different types. So let's stick with the larger, more common conditions and talk about treatments. So help us think through what you're thinking with regard to treatments when it comes to osteoarthritis versus rheumatoid.
So when I'm seeing someone who's been having joint pains for some period of time, I will always ask them, well, have you tried anything? Usually people have taken something, some over-the-counter anti-inflammatories, but it didn't help. You can't stop there. This is, like 20 questions as a doctor. Well, what do you mean by that? How many did you take? Did you take it twice a day? Did you take it for a few days at a time? If someone's just kind of chasing a pain here and there, it doesn't really help. If somebody says, oh, when I take 2 twice a day, my pains are great. When they tell me that, my concern that they have some major immunologic inflammatory condition is really lower because it's not going to respond to low doses of over-the-counter anti-inflammatories. If they come to me and they've been on a bunch of different prescription anti-inflammatories, and they say, well, I went to a walk-in and they said, you have something bad, let me give you a dose pack. And I felt amazing for a few days. And then as soon as I stopped it, it came back. At that point, I'm like, wow, that sounds like there is something truly inflammatory going on. And I'm going to be doing some investigating. And they've, at that point, proven that whatever they've got is not adequately responsive to some of the NSAIDs, as we call them. And while I'm awaiting some of the lab results and testing I'm doing, I will frequently put them on some relatively low-dose prednisone to make them feel better and to see how much better they feel. The other is a lot of the inflammatory types of arthritis typically respond really well to relatively low doses of prednisone, which has lots of issues long-term, but short-term, it's magical. And I don't actually like dose packs because they give too high a dose with a quick taper. Everyone feels great on a dose pack. It's like, super vitamin mix, it's too good. It doesn't help diagnostically, and it's too quick a taper. So from a rheumatology standpoint, I would say I rarely, if ever, use a dose pack. However, 20 milligrams, 15 milligrams of prednisone, if someone feels really good with that low, medium dose, that tells me this could be an inflammatory arthritis. If they don't feel better with that, then it's unlikely, or it's less likely to be so. So osteoarthritis doesn't tend to respond well, doesn't respond as predictably to some prednisone. So typically I'm trying anti-inflammatories first, and that goes for either low-grade inflammatory arthritis or osteoarthritis. But then like the prednisone stuff, that's not really something we're using for osteoarthritis, which is not inflammatory, it's more mechanical. But then beyond that, there's a whole host of different medicines that we've been using for years and years.
That's great. And I'd love to end our discussion just talking through some of the lifestyle interventions that you might recommend in addition to some of the treatments that you've talked about.
So I think with the inflammatory arthritis is like rheumatoid, people sometimes say, well, should I be doing, different exercises? And frequently, if they've got a lot of inflammation in their joint, doing exercises hurts, but I don't want them doing things. If their joints are actively inflamed, I don't want them putting stresses on the joints because the ligaments and tendons may kind of like move around them in ways that aren't good. So once we cool the inflammation down, then I think there is a tremendous role for occupational therapy and physical therapy at really helping people do specific, like strength training exercises of the muscles around different joint areas. So that's clearly got a major role for rheumatoid and other types of inflammatory arthritis. It's a critical part of osteoarthritis, whereas we said, it's wear and tear. And so the exercises and strategies to strengthen the muscles and tendons and ligaments around the affected joints, especially, for example, the knees, are critical to decrease pain and help support the joint better. I mentioned that the osteoarthritis joints that are weight, so taking off if there's excessive weight is huge. A fact which I tell people frequently, especially with their knees, is the mechanics of walking are such that every time somebody takes a step from one leg to the other, the loading on that leg and on that knee feels something like 3 times their actual weight. So if someone weighs 200 pounds, I'll say to them, every time you step onto that sore left knee, it's feeling 600 pounds of weight. Think about that. And their eyes will pop open like, oh my God. And I say, well, one of the reasons that's very important is small amounts of weight loss. It can make a huge difference in how your knees feel. So if you lose 10 pounds, it's like you've taken a 30-pound backpack off your back. I have people who lose relatively small amounts of weight, and they're like, I can't believe my knees are already feeling better. In addition, doing some exercises like to strengthen their quadricep, their thigh muscle. Oh my gosh, if they basically do something as simple as while they're sitting down, I tell this to people 10 times a day, while they're sitting in a seat, they wake up, straighten out their knee, kind of put their leg straight out. Don't move their hip, just straighten their knee out. Hold that for 10 seconds and then let it down and rest and do the other leg. Same thing, hold it for 10 seconds. I tell people do that 15 times, each leg alternating. That's 30 times, 10 seconds, 300 seconds. It'll take 5 minutes. I say, if you do that 5-minute exercise while you're sitting, at least 3 times a day, 7 days a week, I guarantee in a month, your knees will feel better going up and down stairs, getting up out of a chair. And I have rarely been proven wrong. It's a matter of doing it. And they're like, I can't believe it was that easy to make my knees feel somewhat better. So exercise is critical, and weight loss in that way.
And that's a great tip because it's a functional tip. It's just going to be helpful for getting up and doing your daily activities. Thank you so much. You've covered so much ground today. I really, really appreciate your time. So, as we're closing out our episode, can you leave us with some bite sized action items that someone listening today can implement in their daily lives to feel better if they have a diagnosis of arthritis?
So I think that many people, especially when they have other medical conditions that are higher priority, so to speak, don't bring up some of their different areas of joint pain enough, probably to their primary doctor. And I think if they're having pain somewhere and they're not able to do things, they need to sometimes be a little bit more insistent on bringing it up. And if their primary doctor is not comfortable doing the kind of exam needed or whatever, then they should be seeing whether a rheumatologist or a physiatrist, a physical medicine specialist, sometimes an orthopedist. Nothing against my orthopedic colleagues, but I tend to not encourage people to go to orthopedists for the shoulder pain unless it needs surgery. They're surgeons. They're very good at doing these exams, but I think sometimes they're going to get a little bit more TLC by getting examined by a physiatrist or a rheumatologist who sometimes has a broader kind of perspective on the things.
Well, thank you so much for being with us today. We have talked with Dr. Robert McLean about many things arthritis. So, thank you so much for talking us through what it means to figure out whether the joint pain that you're having is actually pain in the joint. And then talking about the importance of getting an exam and then thinking about what you're actually treating and various methods for pain management, both whether it's medication or some of the lifestyle interventions that Dr. McLean shared. To find out more about Dr. Robert McLean, visit northeastmedicalgroup.org. Thank you so much for listening. Please take a moment to follow, rate, and review this podcast on your favorite listening platform. If you'd like to send me an email about topics you're interested in or questions for future guests, please send me a note at webmdpodcast@webmd.net. This is Dr. Neha Pathak for the WebMD Health Discovered podcast.